Hello everyone, welcome to Mid Adventure. In today's episode, we'll be having a discussion on falls in elderly. The objective of this episode is to understand the public health burden of falls, identify common risk factors, describe the clinical evaluation approach and assessment tools, explain the preventive strategies and options. Falling down accident is a common cause of morbidity and mortality in the elderly. 30% of people over the age of 65 fall each year, and the rate increases to 50% among people over 80. And recurrence happens in half of these patients. Falls lead to mild to severe injuries. It accounts for 10 to 15% of all emergency department visits. Falls are the leading cause of injury-related deaths in patients older than 65. Falls can also result in psychological sequelae besides physical consequences, decreasing the quality of life. Now let's see what frailty cycle is. Frailty cycle is a self-reinforcing cycle. As the name implies, it's the inability of the body to recover itself after a stress or a challenge. It begins with decreased physical activity in the elderly, which results in sarcopenia or wasting of the muscles. This then results in decreased muscle strength, which in turn results in unstable or slower walking. Unstable and slower walking then result in falls. After fall down accident, patients will have fear of falling, therefore they will have decreased activity. This then fits the cycle. Now let's see risk factors for falls. Causes of falls are multifactorial. Falls usually happen when intrinsic patient vulnerabilities interact with environmental hazards. Intrinsic factors are neurological conditions, cardiovascular causes, musculoskeletal factors, sensory impairment, medications, and polypharmacy. Now let's see each one by one. Neurological conditions affect balance, coordination, strength, or awareness. They affect gait stability and reaction time, significantly increasing the risk of falls. These conditions are stroke, Parkinson's disease, seizure disorders, peripheral neuropathy, cerebellar disorders, and dementia. The higher the cognitive impairment, the higher risk of falling down accident. Now, cardiovascular conditions. Cardiovascular diseases may also increase the risk of falls. Orthostatic hypotension is the commonest cause. Structural heart diseases like aortic stenosis, arrhythmia, and carotid sinus hypersensitivity are also causes for falling down accidents in the elderly. Musculoskeletal factors impair mobility and stability. These factors include aging, which is associated with sarcopenia, osteoarthritis, foot deformities, and vitamin D deficiency. Now let's see metabolic causes. These conditions cause dizziness, weakness, or confusion. This includes hypoglycemia, electrolyte imbalance, dehydration, and anemia. Sensory impairment is also another cause of falling down accident in the elderly because balance depends on visual, vestibular, and proprioceptive inputs. Visual impairment from cataract, macular degeneration, vestibular dysfunction, and peripheral neuropathy disrupt spatial orientation and increased instability. Polypharmacy is strongly associated with falls, and medications like sedatives, benzodiazepines, antidepressants, antipsychotics, antihypertensives, and opiates increase the risk of falls. Now let's see the extrinsic risk factors. Extrinsic risk factors are environmental hazards like poor lighting, loose rugs, slippery floors, lack of handrails, and inappropriate footwear can transform minor balance problems into serious falls. Screening for falls should be done annually or if patient presents after falls. You begin by asking, have you fallen in the past year? If the answer is yes, you proceed with fall risk assessment. If the answer is no, you continue asking, do you worry about falling or do you feel unsteady when walking or standing up? If the answer is yes, then you continue with fall risk assessment. If the answer is no, you focus on prevention. Fall risk assessment is evaluation of a fall beginning with detailed history. Ask what happened before, during, and after the fall. Previous history of fall is the strongest predictor of future falls. Physical examination begins with the vital sign for orthostatic hypotension. A cardiovascular exam helps to identify arrhythmia and valve abnormalities. Neurological exam evaluates strength, sensation, coordination, and cognition to detect conditions like stroke, neuropathy, or Parkinson's disease. Gait and balance tests such as timed up and go tests assesses mobility and stability. To perform timed up and go test, ask the patient to stand from a chair, walk 3 meters, ask the patient to turn and return in seat. Completion time greater than 12 seconds is associated with increased risk of fall, or if the activity is low in quality, that means the patient might stagger or the gait is unsteady. Finally, vision, feet, and footwear are examined because poor vision or unsafe shoes can significantly increase fall. Investigations are guided by clinical suspicions rather than performed routinely. ECG is recommended. Lab tests look for anemia, electrolyte imbalance, and vitamin D deficiency. Brain imaging is reserved for patients with head injury or new neurological deficit. Now let's see complications. Falls can result in fractures, especially hip fractures, which carry significant mortality rate within the first year. Head injuries, including subdural hematoma, are particularly concerning because symptoms may appear gradually. The other complication is psychological consequences, such as fear of falling, which can further accelerate physical decline. Strategies to prevent falls include exercise, which are structured strength and balance training, medication review, vision correction, vitamin D supplementation for those with deficiency, and home safety modifications. Key takeaway from this episode is falls are not normal consequences of aging. They are often a warning sign of underlying disease. Thank you guys for watching this episode. Hope it was informative. Please don't forget to like, share, and subscribe for more.